Hi, it's Dr. Centeno, and thanks so much for joining us today. You've got the power. Getting started on time today. Let me just put my earphones in here. So we're going to start today just continuing the conversation about high quality spinal injection care involving PRP or quote stem cells. And this is a topic that I've covered a number of times before, a little bit here, a little bit there, but today's show will be dedicated to that topic. And the reason why is that I continue to see clinics that are offering really substandard spinal care, and because they don't have the expertise to put these things where they're needed, they've come up with all sorts of crazy reasons why they have providers who can't do this type of work, who are actually doing this type of work. So anyway, it's a big issue. A lot of patients are getting scammed. A lot of patients are paying a lot of money for very low quality care. So it's worth a more formal discussion. As usual, I'll start with a short presentation and then we'll go into questions. You can ask questions about this topic or really any topic at all. So let me go ahead here and share my screen. Let's see here. Looks like that worked. And so we will go ahead and get going here. So the focus of today's presentation, and again, short presentation and then Q&A, is the top 10 red flags in spinal PRP and stem cell injections. I'm going to put stem cell in quote there. And again, the focus is what's going on out there. Why do we see that about 90% of all of the spinal injection care being delivered is in that low quality category, and people are paying Gucci and Louis Vuitton prices for a cheap Target bag made in China. So let's get into this a little bit. Again, it's very hard for patients to understand if they're getting high quality spinal regenerative care involving PRP, stem cells, bone marrow, or adipose injections. And it's hard because unlike other areas where you can go read a consumer reports guide on a specific product and you can find, well, product A was made very cheaply. However, product B is actually made very well. It's harder for consumers to dissect this because it all lives behind a curtain, if you will. So without seeing the red flags, you don't know what's behind that curtain. A little bit like the Wizard of Oz and the guy behind the curtain. Are you getting high quality care? Are you getting low quality care? It's very hard for patients to figure that one out. So as you know, I created this a long time ago now, and the focus here is to try to say that these simple injections here can help some patients. So they're not absolutely worthless by any means, but they are nowhere near the complexity of, or as good as for most patients, as level 3 injections, or if that person needs it, a level 5 injection. And yet we tend to see providers that are offering these blind spinal injections charge ridiculous prices, or sometimes they're priced appropriately, but many times they're priced very, very high. And in the consumer world, it's very easy to look at these two cars and draw on our experience as consumers is to say that car A here is not the same thing as car B, right? Car B would be a much higher quality. I don't know why my pen is doing that. But car B is going to be a much, much higher quality car. But we can't do that, or most consumers can't do that in the world of spinal injection care. So how do you tell, or what are the red flags that you can look for as a patient to see if you're getting low quality injection care? And listen, if you're getting low quality injection care and you're paying, rock bottom prices, and you don't really need high quality injection care, then that's all good. But for most patients, they're getting ripped off based on what it is they're getting, what it is they think they're getting. So these are the top 10 red flags we'll go through. No imaging guidance, facet capsules, larger than required needles. That's a shout out to one of our viewers here. A physician without a background in interventional spine, using fluoroscopy without radiographic contrast, injecting the upper cervical spine without digital subtraction angiography, using umbilical cord stem cells based on Morton's jelly, stating the stem cells will go where they're needed, IV stem cell injections, and the procedure is performed by a mid-level or a naturopath. So no imaging guidance. You've heard me say this one lots and lots of times, that blind injections are below the standard of care in 2023 or in the 2020s in general, and that a physician should be using a combination in the spine, at least, of fluoroscopy and ultrasound guidance. Now, that's fluoroscopy with contrast confirmation, and I'll get into that a little bit later. Ultrasound alone is not adequate enough to deliver high quality care in the lumbar or cervical spine. It's better than no guidance at all, but it's not adequate. And then blind injections are just absolutely inappropriate. So that's the first question you as a patient need to ask the provider. How are you going to do this injection? Are you going to use X-ray guidance and ultrasound? And if you're using X-ray guidance and ultrasound, are you using radiographic contrast to make sure you are where you think you are? So for example, here, you as a provider, I can put a needle on the X-ray somewhere in there, but it's this radiographic contrast that then gets injected that shows me that needle is going to inject the stuff, in this case, epidural through a transforaminal approach. Without that, I don't know where that stuff is going to go, even though I may think I do. So that's what we're talking about here. Next topic, facet capsules. This is an interesting one because we see this a lot. And in general, when you hear the term, we inject facet capsules from a provider, and you've heard me say this a lot, it often means that the provider is incapable of injecting inside the facet joint and or plus or minus the facet capsule. And it's really just a euphemism for I place the needle somewhere in the vicinity of the facet joint. I don't have any idea if I actually injected the facet or the facet capsule. It's kind of in that area that I injected. So it's usually a huge red flag when you hear that term. This is for Alexi here, larger than required needles. It's just an interesting observation that very high quality spine providers tend to use 25 gauge needles. They're smaller. They're more technically demanding to use, but they do less tissue damage. So we tend to see less experienced spine providers that use 22 or 20 gauge needles. Now for needle gauges, the bigger the gauge, the smaller the needle, the smaller the gauge, the bigger the needle. So there's just no reason to use really big gauge needles because it's just going to do more tissue damage. Another one we see is the physician without any background in interventional spine. So the accepted most common medical specialties with additional interventional spine training would be physical medicine rehab, anesthesiology, interventional radiology, sometimes a few, not many, interventional neurologists. But for instance, if you see someone whose qualification states that they're an ER doctor or a family doctor performing these procedures, then they probably have not received adequate training in interventional spine. It's, again, the mark of a lower quality procedure. Now, there are always exceptions to the rule, but it's important to realize that in general, this is a red flag that needs to be looked into. Another one is when I talk about, and I want to just review it quickly again, and that is using fluoroscopy without radiographic contrast, because we have at least one clinic that I know of that uses fluoroscopy to place the needle in general spots where these X's are. But without using radiographic contrast, as shown here to the right, there is just no way to know where that stuff is going. And I could teach someone to do what's on the left, to just place a needle in certain spots on an X-ray inside of a weekend course. But to do what's shown on the right and get it correctly, in this case, in the facet joint or epidural or into other specific structure, is very difficult to do. And it takes a full year of fellowship training or more to be able to do that. So again, that's another question you should ask. I see that you use X-ray guidance or fluoroscopy. Do you inject radiographic contrast to make sure you are where you think you are, or the stuff is going to go where you think it's going to go? And if the answer comes back, well, we don't need to do that, we just place it where it needs to go in the X-ray, then again, you're looking at low quality spinal care. Another one that I've talked about before is using digital subtraction angiography. So digital subtraction angiography, when you're injecting the upper cervical spine, is making sure that you're not injecting that stuff into, in this case, the vertebral artery, that it's actually going into the joint. And we see this quite a bit out there. Even doctors who have been trained how to do this kind of stuff, these digital subtraction angiography packages are usually used in interventional cardiology. Most of the time, doctors who are doing this kind of work, even if they're very experienced, haven't bought that package because about $20,000 additional when you buy the C-arm. But it's necessary to inject the upper cervical spine safely to make sure you're not injecting into that vertebral artery and stroking out the patient. So this is what digital subtraction angiography looks like. Another red flag to look for is using umbilical cord stem cells, in quotes, based on Wharton's jelly. We did this study a couple of years back. We published it in the world's most respected orthopedic journal, the American Journal of Sports Medicine. And we tested 5 Wharton's jelly products. We worked with the Colorado State University Translational Medicine Institute, where we split the task of doing this study. And we saw no viable and living stem cells that went on to culture in Wharton's jelly products that were available here in the United States. And those products are listed there. Now that's in comparison to bone marrow concentrate. So the ones on the top that are all white show no stem cell colonies. The ones on the bottom that have those little purple dots, those are stem cell colonies in the bone marrow of elderly patients. So these products are frequently sold by providers as having millions of healthy and vital stem cells. They actually have no living stem cells at all. And they have far fewer stem cells, i.e. 0, than lives in the bone marrow of even elderly patients. So if you see this, you automatically know that the provider has no idea what they're talking about, and you need to find another provider. Another one we hear is that stem cells are magic. They will go where they are needed. So if you just give them IV or you put them somewhere in the general vicinity, they will go where they're needed. Now, that is just total fiction in the spine. We have no data that shows, for instance, that stem cells injected into spinal muscles go into spinal discs, or even any way for them to get into spinal discs. or that stem cells injected into spinal ligaments or superficial structures are going to end up around damaged nerves in the spine, etc. So this is a classic sort of bait and switch that we tend to see. Another one is an IV stem cell injection. Again, we have no evidence that stem cells injected into a vein in your arm or elsewhere end up in the spine in areas where they're needed, and most of those areas needed repair are avascular or poorly vascular, so you've got to put those cells exactly where they are required. Now, why do we still see this out there? Because it's cheap. That's the bottom line, is you can find a medical assistant who can start an IV for $20 an hour, whereas a doctor who would place this stuff into the right C1, C2 facet joint or around the right L4 nerve is going to command $300 an hour to do that. So if you're a clinic and you can convince someone that this is the same, if you pay $20 an hour to start an IV, you're going to make much, much more money than if you pay some doctor $300 an hour to put it exactly where it needs to go. And then finally, the procedure is performed by a mid-level or a naturopath. Listen, at the end of the day, there is no way to get a nurse practitioner or a PA as educated as a physician specialist. It just doesn't exist. In the same way, there's no way to get a naturopath who's as educated as a physician specialist. So we tend to see this a lot. We see clinics who hire mid-levels, physician's assistants and nurse practitioners, claiming that they're the same as a physician specialist. They're not, or a naturopath. And really, this is just the same game we talked about before, right? It's cheaper for the clinic owner because they can pay these folks a third or less of the amount that a physician specialist would command. So it's just a business decision, and one that's not benefiting you as the patient. You're paying the same amount for far less expertise. So in summary, it's not hard to figure out if you're getting poor or low quality spinal care, but you do have to know about these red flags, ask about them, look to see if all this stuff is on the website. If not, talk to a person at that clinic so you can see if you're in that world of getting care that just isn't up to par. Okay, so let me stop this and we will go to questions here. See if we have any questions. Looks like we do. So let's start with those questions. Hello, what is your executive assistant's email address, contact info, please? I apologize, I know you've done it before. Sure. So right now it's Carla. That's going to be changing to Eric, but I'll put Carla's down here, her email. And then Eric's email, let me make sure I can get that for you, because that one I know. Let's see here. So the other one would be Emaza, Eric, E-R-I-K, at the same. So at Centeno-Schultz.com. So we're transferring from Carla to Eric, but I put both of those down there, and hopefully you can see those. So there, that's in the comments there. John Hull, in a study by Coe et al., they successfully treated moderate severe SI joint laxity with leukocyte-rich PRP and with the treatment. Like you said, PRP is only twice as strong as compared to Prolo. I don't think they treated SI joint instability, at least based on the ones I have seen that are randomized controlled trials. So if we go to, let's see, let me pull this apart so we can share this. Or I can share this. So if you go to the Regenexx site Let me go to share screen. So if you go to the Regenix site and you were to go to search here, actually I tell you, just go to the blog. It's right up top there right now, at least. So if you look at the 2023 PRP RCT infographic and study failure analysis, and we look at all the different PRP high-level research studies, that'll take a second to download because it's a large file. And we go to SI joint pain, which is at the bottom here. Let's see if I can make that bigger. No, it's not going to work. So we have two studies here on SI joint pain. What is the Singlis study? And these are really intra-articular injections, so they're treating SI joint pain, not SI joint instability. So that's Singla. And the other study that's here, that's a randomized controlled trial. Let's see if I can get it to open. Would be Chen. And these are both where they ended up, these are randomized controlled trials, usually against corticosteroid or saline. And they're injecting intra-articular. They're not injecting the ligaments to treat SI joint instability. So those are the two we have on sacroiliac joint pain. As far as treating SI joint instability, we don't have a randomized controlled trial. Now, there may be a case series on someone that tried to treat a couple patients, but that's going to be different than the evidence of a randomized controlled trial. As far as in general, what that looks like when it comes to most patients with SI joint instability, if you look at prolotherapy type treatments, and that's going to be mostly women. So if you look at prolotherapy type treatments in women, it's basically 4 to 6, somewhere in there, SI joint ligament treatments to try to get rid of SI joint instability. If you have that, it's approximately what you get for PRP. So let's say 2 to 3. And then if you wanted to use bone marrow, that tends to be more of a one and done. So that's kind of in that same range that we've been talking about, but we don't have a randomized controlled trial on that. That's my clinical experience. Let's see here. Let's go ahead and stop the screen sharing. What is your take on thermal shrinkage potentially being used in EDS patients to tighten shoulder or hip capsule? Certainly one way to go. I don't know that it's required though, meaning that in thermal shrinkage, you're doing damage to the collagen, and it's going to be far less controlled than a image-guided injection of something like prolotherapy or platelet-rich plasma or bone marrow concentrate. So I think it's probably not a great idea, given those competitive treatments for the same issue work well and can be controlled much more exactly by injecting into very specific structures. Andy, if the feeling of a heavy head is pretty common in CCI patients, why isn't it common in rheumatoid arthritis patients with C1-2 instability due to a lax transverse ligament? I don't know that it's not common in rheumatoid arthritis patients. Those patients are few and very, very far between. And they would tend to be seen mostly in rheumatology practices that have older patients with rheumatoid arthritis. So again, but we're kind of talking about apples and oranges there, because in a rheumatoid arthritis patient who is end stage enough to have upper cervical instability, we really tend to see large amounts of displacement where, for instance, the dens is pushing into the medulla, the spinal cord, or there's been complete destruction of certain areas, bones, or joints. So it's kind of a different animal altogether than a patient with craniocervical instability in this world, where it's more movement-based problems hitting into structures that shouldn't be hit into. John, a rough estimate, how many EDS patients have responded very well to PICL procedures when it was first created? Yeah, it's a good question, John. I don't know. The last time we looked at this was last summer. And at that point, EDS patients in the data set represented, I want to say, about 1 in 5 or so. And it's increased since then. So we're probably maybe up to about 1 in 3 or 1 in 4. And the success rate is about 7 in 10. So if you do the math there, and we've done 1,000 procedures, let's say in around 400 patients, the numbers you can sort of see are probably going to be 50, 60, 70, something like that, because we would have an increasing amount of EDS patients over time. Ulysses, where does the nuchal ligament start at? Nuchal ligament would officially be from C1 to the back of the atlas to the skull. John, how do you distinguish whether symptoms of EDS patients being caused by POTS versus CCI? What do you typically do better help your decision making? Well, POTS isn't a thing, meaning that POTS isn't a diagnosis or a diagnostic cause, it's a descriptor. So that brings up an important point. We have to put diagnoses into 2 categories. We have the descriptor diagnoses, which simply describe what's going on, postural orthostatic tachycardia syndrome. So that doesn't tell us what's causing the orthostatic tachycardia. That just describes the symptom or a sign that goes with the problem that a lot of people have. Then you get into the cause, which would be something like craniocervical instability or damage to the vagus nerve, et cetera, et cetera. So we're really not comparing apples to apples there. We would need, if you wanted to get into that, you might say in someone who had a stab wound or a gunshot wound in their neck and the vagus nerve was damaged, how does that compare to someone with CCI? Both of those could end up causing postural tachycardia or orthostasis. AT, how often do you see full back chest tightness from CCI, unless the frequency resolves after PICL? Full back chest tightness wouldn't necessarily be by itself a CCI, common CCI problem. A lot of CCI patients have upper back pain, but they wouldn't describe it as that as being one of their biggest problems related to CCI. So in general, the answer is that's not something that would be commonly associated with CCI. Andrew, can very mild laxity in the upper cervical ligaments that is chronic be treated by a hard collar? Maybe can cause some ligament contracture or better yet a small healing response. Well, certainly if you have an acute injury, you can always look at trying to immobilize the area, and there's a risk and benefit to that immobilization. If the immobilization is short-term, then there's probably more benefit than risk. If the immobilization is long-term, then there's more risk than benefit. So for example, if you had injured your neck last week in a car crash and you knew you had injured the alar ligament, you could certainly put yourself in a collar for 2 or 3 weeks. You would suffer some muscle loss, but in general, that calculus generally works out. But if you're talking about someone who injured that ligament 3 years ago, would getting into a collar fix the problem? The issue there is you don't have any acute inflammatory response to initiate healing. So just immobilizing it might help a little bit, but you're probably getting into a situation where the overall risk of immobilization, meaning making the stabilizing muscles weaker, outweighs any potential benefit. Stefan, hello, I'm also considering making an appointment regarding stem cells with you. I suffered a blow to the back of the head and I've had unstable upper cervicals ever since. However, my biggest concern is for the therapy. I have to stop my antidepressants as I'm dependent on them. Stem cell therapy possible if I'm taking antidepressants? Yeah, a lot would depend on what the antidepressant is, and the best we could tell you there, Stefan, is listen, there's either data that this is a problem or there's no data that this is a problem. Hence, here's the risk benefit of staying on it. For most medications in that category, it's going to be that kind of discussion. So it's not going to usually be a contraindication discussion, meaning you can't stay on this antidepressant at all. It's going to be more a relative risk discussion of saying, here's the potential risks of this, or we don't know whether this might impede your healing. And these are the potential benefits. So it's not something that you absolutely have to come off of. AT, effectiveness of class 4 laser therapy during after PICL or CBP to aid in ligament healing. Yeah, the biggest problem is laser is light. So it doesn't go any place light can't go. So for example, if you were to shine a flashlight just into a model of the upper cervical spine, not much light is going to get into the ligaments that we're talking about because those ligaments are shrouded by bone. Laser doesn't go through bone. Light doesn't go through bone. Laser means light amplification by stimulated emission of radiation. It is absolutely nothing more than a specific wavelength of light. So if light can't get there, laser ain't going to get there. Yeah, man, that wouldn't be true for the nuchal ligament. I think you'd get into, by the time you get down there, into the vertebral dural ligament and then into the supraspinous, interspinous ligaments. Yeah. Well, thanks, Gabriel. I appreciate it. AT, accuracy of C1C2 overhang possible for tight muscles, skewing measurements. Have you seen where muscles make it seem overhang is less because they're overactive? Yeah, I mean, that's a very good point. And I think it's something important to bring up, right? We certainly know that the body has protective responses. And when things are unstable, it can force spasm. And by forcing spasm, you can reduce the instability. So if you had a lot of upper cervical spasm or just spasm that prevents you from moving your head in a reasonable way, then you may have a false negative DMX, meaning that the instability may be there, but we didn't get you in enough range of motion to see it. And that's a known phenomenon that's been studied in things like flexion extension x-rays, where we're looking for instability in the mid and lower cervical spine. Same problem. If you don't get to full range of motion, you reduce the accuracy of those flexion extension x-rays. Looking for instability in that case. AT, what is the infection rate with PICL? Has anyone reported meningitis or been in a life-threatening state after the procedure? Thanks. Haven't seen a serious infection with PICL at this point, or any reported meningitis or any ICU admissions due to the PICL procedure. That's not to say it's not possible, though, and I think it's always important to realize that any of that or an infection with any procedure is possible. We take a lot of precautions, but it's still theoretically possible. I can say that if we compare that to an open surgery, obviously we're talking about a much higher infection rate or complication rate. So for open upper cervical surgery, based on the published literature, what I've seen and observed as a physician who sees those patients, We've got a serious complication rate of about 1 in 5. And when I say serious, that means that there's something life-changing that happens. Now, that might be simply they slice through the occipital nerve and the person's left with chronic head pain, all the way down to, or as far as the patient ended up in the ICU, or the screw didn't take, or the fusion didn't take, another surgery was required to fix that, etc. So that would all be under that blanket of more serious complications. Amen. Hill at Argentina, a quick question. How come ankle ligaments, for example, heal with rest and cervical ligaments don't heal except with injection surgery? No, I think the difference here is that a certain percentage of ligament injuries just don't heal. I think the big difference, though, between ankle and upper neck is an ankle ligament injury is easier to conceptualize, hence easier to identify. So, for example, you're playing basketball or some sport, you go up and try to do a layup, and you come down on the ankle, and you hear, and the ankle swells up, and so you immediately know that you've sprained your ankle. And then you can look and see there's a percentage of people we'd all accept just get better on their own. There's another percentage of people who get mostly better and they're otherwise fine. Maybe that ankle is always a little bit of a problem. And there's a percentage of people who require surgery. We don't really get that same feedback, though, in the neck, right? There's probably many more ligament injuries in the neck. They're not identified until someone doesn't recover, meaning that we can't see the swelling like we can see it in the ankle. We don't have the usual lay conception that a ligament has been damaged like we do in the ankle. So I would say that we're just not observing this stuff as easily in the neck as we are in the ankle. Regenetics been advanced by Sherry Scott. I'm going to be having a baby soon. Oh, congratulations, Sherry. Is there any benefit to store her umbilical cord stem cells? And one of the companies do that. Yeah, no, it's a little bit of a scam there, Sherry. There's really no reason to store umbilical cord stem cells for a baby. It's a little bit like, and I've said this before, an insurance policy that can almost never pay off. So we all buy insurance, right? We all buy insurance because we know that we may have to use it. So if you buy car insurance, even though there's a low likelihood that you get in a big car crash, you know people who've gotten in car crashes. So you're like, okay, I should buy this insurance because while the risk is low, I know it's real. In this case, the likelihood that you would be able to use those cells for something for that baby, and the only possible thing that could be used for that baby would be a hematopoietic cancer, is about the same likelihood as getting struck by lightning. So it's a little bit like buying insurance for a lightning strike, right? We don't know anyone who's had a lightning strike and died or something like that. So we never buy an insurance policy against lightning strikes because it's too rare. Well, we're talking about the same risk here, being able to use those cells. That baby or that kid will never be able to use the cells for anything else because all of that would have to go through full FDA approval, and that's unlikely to occur. And no one else in the family will ever be able to use those cells. So it's a little bit like buying an insurance policy for a lightning strike. It just doesn't make any sense. But it's a great business plan. I'll have to hand them that. Duck P, can the posterior sacroiliac ligament, long, short, be treated with ultrasound guidance? Yes, it can. That's one that can be for sure. Dub Trip, where can I send my questions? Yes, here, right in the comments there, Dub. It's been advanced by Harry Winston. I've recently had a CCI setback and travel from the UK may not be possible unless this passes. Do setbacks like this generally pass, or is it likely to be new normal? You know, Harry, unable to answer that question given that amount of info, but I certainly wish you the best with your setback. AT, for extreme muscle tightness in the back and shoulders caused by severe CCI, what treatment should one get for the tightness specifically? Dry needling maybe, or is this all usually resolved with PICL? Well, again, AT, we'd have to know, we'd have to look for other causes of upper back pain and identify or treat those causes. It's certainly possible that it could be CCI related, in which case if the CCI resolves, then the upper back pain should resolve. But there are also many other causes of upper back pain. Robert, is there any treatment to eliminate the tightly bound tissue when I get injections, needle crunches through what sounds like glass breaking enough to have to change the needle? I don't know that that's tightly bound. You may have some calcification happening within tissue. So I'd have to know a little bit more, but if it's calcification, then that can be a concern. If it is just tight tissue, then I'd have to know a little bit more about where they're injecting you. Doug, what is Dr. Stem's position on treating Parkinson with stem cells against it, and why? There is no legitimate Parkinson's disease treatment with stem cells at this point. There are several universities working on this, and certainly you can place stem cells into the part of the brain where dopamine is made in the substantia nigra. And that makes sense all day long and twice on Sunday. Now, it still has to be further studied. I know there's at least 1 or 2 universities working on that research. But the idea that someone can hook you up to fake stem cells as far as Wharton's jelly here in the US or some other culture expanded umbilical cord stem cell and cure your Parkinson's isn't tenable. And if it is tenable, they should publish that data, and it has yet to be published. So if I had a loved one with Parkinson's, and I actually do, I don't think I'd go there at this point. There'd be far more interesting ways to treat that. Now, that could change, right? We could be in a world where 3 to 5 years from now, a legit Parkinson's treatment where we're replacing stem cells directly where they're needed comes out, in which case that could be groundbreaking. John, what are your thoughts on the whiplash prolotherapy study by Slagiza, where they did images, guided CEDAR 7% injections using P2G? Let's see here, John. See if we can find that so we know if we're talking about a study or just someone's published experience or what it is we're talking about there. So let me go and share my screen here. We will go to PubMed and we will type in that name. First thing is whiplash isn't a diagnosis. So whiplash is another descriptor, meaning someone who had a neck injury who still has pain. So the question would be, what injury are we treating here? Because whiplash isn't a thing in the medical community. So let's see here. This is maybe we need to get the full text because it looks like they didn't write a complete abstract. So let's see what we got. Let's see what we got on the full text here. So how many patients are we talking about? I guess we got to press there, view the article. Wow, still not coming up. So I don't know how many patients they did, but I don't think they're talking about facet injections here. I think they're talking, knowing who these providers are, because I know these guys. They're really talking about just a traditional prolotherapy approach rather than facet injections. And this brings up a very important point, right? You would read this and think this had something to do with facet injections as we're conceptualizing them here. But instead, this is a traditional prolotherapy approach where they're injecting the ligaments and using what's called a blind Hackett technique. And so listen, as I said, there are certainly patients who injure ligaments in their neck after car crashes who can be treated with a prolotherapy approach. P2G tends to be a pretty aggressive way to treat that. You could probably do it very similarly with 12.5 or 15% dextrose. So there's nothing wrong with that. But here they're using an X-ray to, what I talked about in the presentation, place the needles kind of in the vicinity of somewhere near the facets. Those are called Hackett points, and they're injecting the ligaments, but they're not doing an intra-articular facet injection here, nor are they injecting anywhere near the 0-1 joint. So that's an important thing to bring up. You kind of took the bait here and believed that what it was they were doing was injecting the facet joints, but they're not. It's a Hackett technique where they're just putting the needles kind of in the vicinity of where the facet joints live. But again, that Hackett technique in the right patients can be very effective, and nothing wrong with it at all. AT, what is a typical patient profile for a one and done PICL case? Usually someone who was acutely injured, they identify that they've got CCI fairly quickly within the first couple of months. They don't have something like HEDS, in which case they'll usually require more care, and they get in for treatment within that first year. So that would be the easiest type of patient that we would see who's a one and done. Magda, hydroxynteno is contrast necessary in lumbar spine facet injections. If a practitioner have not used contrast lumbar spine injections, mean that PRP had been injected in a facet joint. Yes, that's what it means. So Magda, you got had, so to speak. Yeah, so there's no way to get into the facet joint without radiographic contrast using fluoroscopy. You can kind of do it using ultrasound, but you still don't know that you're in that facet joint. To the same degree, you know it by using fluoroscopy and radiographic contrast. So what that probably means is they never really tried to inject the facet joints. They did the same thing that John brought up in this one paper. And let me actually get rid of that because I don't need that anymore. In that what they really did was to place the needles kind of in the vicinity of what are called Hackett points. And they called it a facet joint injection because it sells better. And they know that's what patients were looking for. But there's no expert in interventional spine who would consider that a real facet joint injection. So if that's what they told you they did, then you kind of got had. Submitted advanced by DB. Can the vagus nerve cause anxiety and depression? If so, does physical treatment of the vagus nerve fix an issue? Or once that starts, does that become a permanent issue? How is the vagus nerve treated? So here's what we know about the vagus nerve. We know what it does. We know that it's responsible for the chill out response. We know that hence in contrast, vagus nerve irritation, we believe, can cause that fight or flight response or inhibition of the vagus nerve. As far as its links into depression, that's less well understood, but there may be a link there. And if you believe that someone's having vagus nerve problems in the context of craniocervical instability, you treat the craniocervical instability to try to reduce the ongoing irritation of the vagus nerve. As far as direct treatment of the vagus nerve, that's again theoretically possible through platelet lysate hydrodissection, but that's less well understood. Now, the good news is, as I've said here before, we have multiple multi-billion-dollar device companies that are trying various types of vagus nerve treatments for things like depression, for things like headache, for things like rheumatoid arthritis. And those studies are now just starting to come out. So I think we're going to learn a lot more about what happens when you treat the vagus nerve directly here in the next couple of years. Doug, post questions here, yeah. Ulysses will choose osteopath over naturopath to do injections. Yeah, so an osteopath is a physician level provider, a naturopath is not. So for example, an osteopath or an MD, a DO or an MD, both have to go through 4 years of college, 4 years of rigorous, crazy medical school that's incredibly difficult to get into. Right now, probably less than 1 in 100 kids that want to go to medical school can get into medical school. Then they've got to go through an internship treating sick people at a big university hospital. Then they've got to go through some sort of residency program for specialization. And then many go through fellowship programs on top of that. So another 3 to 4 years for residency, another several years for fellowship. Compare and contrast that to a naturopath who basically doesn't need a 4-year degree to get into naturopathic school, who comes out with the equivalent of sort of a master's degree or less, who doesn't really spend much time seeing sick people in university hospital settings, and who has a fraction of the amount of training of an MD or DO. There's just no comparison between those 2 degrees. So very important that you understand the difference between a DO, which is a physician level provider, and a naturopath. In addition, forgetting about the fact that naturopathic school is going to be far easier to get into. It's not going to be 1 in 100 kids that want to become a naturopath can get into naturopathic school because they're for-profit ventures in general. Nisa, when do patients typically get back to baseline post-PICL? That is highly dependent on the patient, but most patients within 3 to 7 days. We have, like I always say, we have a bell curve, right? In the middle of the bell curve are people who recover within 3 to 7 days. Then you have the tails on either end. On one end are those people that don't even know we did anything. They're just a little tiny bit sore and they go about their lives. On the other end, you've got people who take weeks or months to recover, but those are in the minority. These are some of the emails I put up there. Doug, I heard recently about stem cells programming to position the cell where needed. Can Dr. expand on that? I need to know a little bit more about what aspect of that you want to know about, and specifically what you heard, because I can't tell just from that question. Nisa, do patients ever get worse post-PICL? About 5% of patients, or 1 in 20, go through a long-term flare-up lasting 3 to 6 months. When we follow up on those patients, almost all those patients go into the either same or recovered bucket. But we certainly do have patients who have long-term flare-ups, yes. Sure, Patty. Ulysses, what is the best concentration for dextrose prolotherapy for the neck and other joints? Most common concentration used would be 12.5%, sometimes 15%. So somewhere between 12.5 and 15%. Caleb, well, Ulysses, understand that osteopathic physicians usually train an allopathic physician here in the United States. Yes, they are literally the same thing here in the US. Daniel, hi, when I lay on my back, I get pressure behind the eyes. I'm diagnosed with CCI, so I wonder which ligaments can cause that. Yeah, Daniel, so that could be swelling in the dens bursa, or the lubricating sac up there. That could be related to intracranial hypertension, which could be pressure on the internal jugular vein. Lots of different things can cause that kind of pressure. That could be irritation of occipital nerves, etc. Patata, I'm not sure how to pronounce that. Can PRP for CCI-AI help with vestibular issues? I've been diagnosed with DMX and my balance symptoms have gotten worse after vestibular PT rehab. Well, the first thing is what kind of CCI you have as to whether or not PRP would be helpful or which specific structure needs to be treated. But yes, vestibular type or balance type problems after or with CCI-AAI are pretty common, and they commonly get better. Tania, Regenexx London used the same procedure with PRP. Certainly, they can make the same stuff. So yes, as far as the content of the PRP. John, will a ligament injury always result in swelling for a short period afterwards? Usually, if it's significant enough to cause symptoms, yes. Linnea, can you continue taking beta blockers while receiving PRP? Shouldn't be a reason why you can't. John, can you make a video about good or bad versus good inflammation? Sure, John. I have one. I'm pretty sure out there, but it's probably time for another one. John, how effective is nerve hydrodissection? Are there studies demonstrating its effectiveness? Yep, lots of studies on nerve hydrodissection. How effective is it for things like carpal tunnel? Pretty effective, but that's a separate discussion of itself, going through that literature. James, don't know how relevant this question is really, but I was curious if you had any thoughts on the potential benefits of doing things like IV vitamin C for CCI, any other IV therapy. I don't think it's going to help, James. Ulysses, is trigger point injection toxic to the muscles, especially with lidocaine? Yeah, if you're doing trigger point injections, you'd either want to do it without anesthetic at all. That's called dry needling, which is shown to be as effective as when you use anesthetic. Or if you're going to use anesthetic, it would be ropivacaine, which is less toxic to the tissues than lidocaine or bupivacaine. Potato, I'm considering upper cervical PRP over Dr. Otomo Silva. Is that something you would recommend? No, we only recommend Centeno-Schultz Clinic in Colorado for any upper cervical work. It's too risky to get elsewhere. I think I've discussed here a situation where last year a patient had a brainstem injury because they went to a clinic that didn't have the ongoing day-to-day expertise in the upper cervical spine. So no, I don't recommend any clinic outside of Centeno-Schultz for getting any upper cervical care. There's just no one else in the US that's doing these procedures at the rate that they need to do them to be extremely competent in treating that part of the spine. Now, that's very, very different for the lower neck or for the lower back, where clinics like Dr. Silva's would be, more than competent to do that work. John, what do you personally think are the potential causes of POTS in hypermobile patients? One theory is that there's some laxity in connective tissue that lines the leg vessels, which causes pooling. That could certainly be one of the potential causes. Another would be vagus nerve irritation. There may be other things that we don't understand, or there may be different subtypes of POTS within the various subtypes of EDS that cause hypermobility. Mark, I had a high school classmate that recently passed away during her 9th surgery for scoliosis. Her first 8 fusion surgeries had failed. Apparently, the surgeons were trying a new procedure where they were removing a pie-shaped piece from her spine. So this is something I've heard of. I'm sad and confused as to why surgeons were trying to do and been able to find any other info on this. Yeah, well, thank you, Mark. And I just want to say I'm sorry for your loss. Yeah, listen, spine surgery is a big deal, right? I think we don't want anyone to go into spine surgery with the idea that it's routine, or the idea that it's like going in to the mechanic and getting a part changed or a part installed or something installed in your car. There are catastrophic effects of spine surgery. And in general, if we're talking about lumbar or cervical fusion without talking about CCI, we're talking about fairly high complication rates. Again, depending on who you read, somewhere between 10 and 20% of patients are having some sort of serious complication. Then we get into upper cervical spine surgery, and those complications jump up. So what were they trying to do there? It sounds like a corpectomy. where they were trying to remove maybe a portion of the vertebra, but that can go incredibly wrong. So I'll give you a great example. Just locally here many years ago, there was a family physician who needed neck surgery, had way too much blood loss during the procedure, woke up blind. Obviously, he was no longer a family doctor after that. And that was just because there was too much blood loss during the procedure. Blood pressure got too low. There was poor perfusion in the occipital lobe, and just had an occipital lobe event. So yes, these are big procedures, and I think everyone who needs them needs to go in to them eyes wide open, understanding those risks, and obviously should do everything short of surgery to try to get rid of the problem. AT, do you compare the range of motion specifically when taking multiple measurements of sequence to overhang for patients? Yes, we do. So we trying to compare apples to apples before and after, we try to make sure that we got the same amount of lateral bending. And or, I think as we've already discussed here, if we see a patient who doesn't seem to have much overhang, but also doesn't have much range of motion, we'll talk to that patient about going back and getting it redone, or perhaps taking some medication like Valium if they go back and get it redone. Bill, have 3 bad discs on MRI of the cervical spine, C3, 4, 4, or 5, 6, 6, 7. Closer to Idaho Falls location, but better off having you review the imagery, more experience versus Idaho Falls. Bill, I don't do that many lower cervical spine cases anymore. I'm very specific on seeing upper cervical or CCI patients. Now, certainly my partners here at Centeno-Schultz would be happy to take a look at your images to try to see what you need. But Regenexx locations that do spine generally are capable of doing those procedures in the lower neck. For the glass-like tissue locations of occipital muscle attachments. Yeah, so there may well be some ossification there, meaning some calcification where the tendon attaches to the bone. And so that's definitely something to consider or look at to see what's there. Jeff, what's your view on the qualitative differences between a Regenexx PRP procedure and what you would generally be found in a hospital or sports medicine office? Yeah, Jeff, a lot of that depends on what it is the patient needs and what it is being offered. So for example, for the average 20-year-old, the biggest difference is going to be the ability to put that stuff where it needs to go. So in an orthopedic surgeon's office, that's going to be less likely because they don't really have image guidance training. In fact, we retrain orthopedic surgeons all the time through the Interventional Orthopedics Foundation. But that person also doesn't need a high-dose PRP, so they would probably be fine with a low-dose PRP that could be found in something like an office that has a bedside centrifuge. Then we get into older people, people my age, 40, 50, etc. There we need higher doses to maximize that effect. In that case, just the PRP becomes a big problem, right? So for instance, to maximize tendon healing for an Achilles tendon tear, you should have 10 to 14x concentrated. The average bedside machine can produce 4 to 6 times concentrated. So you're getting underdosed in that clinical scenario. So a lot of it depends on who it is and what they need. John, well, actually I have access to the whole Whiplash paper. They have images of contrast dye and Caesar using X-ray guidance. John, send those to me. I'm happy to take a look. So you can send me that. I'll put my email address down here, and maybe we can go over it on Friday. If they were putting P2G into the C01, then that's a problem, because the P2G is phenol 2% glycerin. It would be by definition neurotoxic. So if that stuff got inadvertently injected into the vertebral artery, that would be a very serious posterior circulation stroke. So I'm happy to look at those and see what they show. Darian, how do you imagine AI will play a role in regenerative medicine in the future? Well, I think AI is going to change medicine, but true AI. We're not talking about ChatGPT here. But I think as that type of technology develops to general AI, or at least a broad-based AI, I think we will see AI being involved in medical decision-making. We'll see AI being involved in reading images. So we will see a bigger role as time goes on. AI will be involved in picking the best treatments, etc. So I think there's a big role, but that's in the 10 to 20 year time horizon. I don't see it dramatically changing medicine in the next 5 years like it will probably dramatically change computer programming, for example. Darian, can BMAC injections be repeated every year? I guess they could be potentially. I just would need to know clinically why you would want to do that. Dub Trip, some clinics in Cayman Island do offer stem cell for Parkinson's via IV injection. I understood you think this is ineffective, but will it have the risk of health problems? Yeah, I wouldn't do a stem cell treatment IV in the Cayman Islands for Parkinson's or anything like that. There's no publications on using the type of cells they're using at that clinic to show that that's safe or effective. And when it comes to safe, that's a huge, big study to do, right? Once I inject something IV, I'd have to do an extremely large safety study looking at multiple areas of the body to make sure I'm not hurting that patient. Quite different than if I just inject cells into a knee, or I know that I need to look at the knee to see if I have hurt the knee. Darian, have you done injections yourself? What do you do to treat? And what is your experience? You mean on myself? Darian, you may want to obviously do procedures every week, but I think you maybe mean on myself. And the answer is yes, I get injections all the time. I had just gotten some injections in my shoulder this last week, and we'll get probably some more this week. Thatcher, AT, yes, the lateral head rotation was painful for me. Maybe ask the EMX provider to help hold the head. Or just take some medications. But if the decreased range of motion is fibrosis, meaning due to scarring, then there may be no way to get around it, but certainly medications would be a good first step. And do you prefer MVX, X-ray video, or MRI? More DMX, digital motion X-ray. But again, they're two completely different things that find different things. So we would need, at the very least, a routine cervical MRI and a digital motion X-ray. If we also have a functional upright MRI with flexion extension, that can take the place of a routine cervical MRI, and it gives more information. AT, the reason I was suspecting tightness in the back and shoulder is because I have severe CCI. I feel like the area is pulling on my upper cervical. Yeah, so I mean, again, that could be due to things like levator scapula pulling, or it could be a totally different problem altogether. Thanks for your videos. When you're going to be on vacation and how long will you be unavailable for? I will be gone in the fall from September 15th to October 30th. I'll continue to do evals at that time. Once a week. So I'll continue to see patients online, but I'll be out of the office during that time. And generally, what I did last time is what I'll probably do this time again, is I put together a bunch of videos, recorded those, set those to go out on a weekly basis. So there won't be a Q&A, but there'll still be content going out during that time. Ulysses, how was the patient doing who was in rehab after the brainstem stroke incident? I don't know exactly, but it's my understanding that not well, but I don't have much follow-up. But that's just figuring with regard to what happened and the follow-up care that was required. And I'm considering getting an occipital stimulator prior to coming to see you for my CCI evaluation for PRP. I live in New Jersey and need immediate relief. Left side of face and head pain. What is your opinion on this? Pretty bad idea. That's my opinion on that. Listen, once we place an occipital nerve stimulator, we're destroying tissue to do so. There's just no way to get around that. Now, hopefully it's minimal tissue destruction, but there will be some tissue destruction. So I don't think that that's a good idea. That's a more aggressive and invasive treatment than treating CCI posteriorly with PRP. So you're kind of getting it backwards there, right? You usually go with less invasive treatment. You try that and fail that, and then you go into more aggressive treatment once that fails. So when it comes to an occipital stimulator or any type of implantable device, that would be some of the most aggressive and invasive interventional care offered. So you would want to make sure you fail things that are less invasive than that first. Jeff, in a patient going for PRP, is Prolo always recommended? I'm not sure what you mean by Prolo. If you mean if someone's getting posterior PRP, let's say in the facet joints, are the ligaments frequently injected? They are. Dennis, what are your thoughts on using peptides to heal tendons and ligaments? Probably no better than a scam right now, meaning that we have no way to know what it is you guys are buying actually is what it says it is. And if you look at things like BPC 157 and the results, it's about the same as PRP. So why wouldn't you just use PRP, where we have 107 randomized controlled trials, versus BPC 157, where we have 0 high-level clinical data or any clinical data to show that it works. David, hello, can you please share with me why so many places say they do work as in stem cells, but it's always better overseas? Why is this? Why so many places here say that they do stem cells? Well, it's not always better overseas. I mean, the biggest problem with going overseas is going to be that the quality of medical care goes way, way down once you leave the United States. That's just the reality. So, for example, I've covered and talked about a Mexican clinic, right? The Mexican clinic, here's a great example. The patient was getting an umbilical cord stem cell injection. Who knows if they're actually umbilical cord stem cells or not, but forgetting about that. We found a video of a crazy doctor who took a needle and tried to put it directly into the carotid artery so that the cells would get into the brain. Now, here in the United States, that would be done in a interventional cardiology procedure suite that costs $1 million, and they would never have gone here because the risk of stroking out the patient is too high. They would have floated a catheter under dual X-ray fluoroscopy guidance and contrast confirmation up into this area and then squirted it to get it into the brain. So as you can see there, the Mexican clinic care was dangerous and so different from the real care that it was frightening to physicians who understand what that should look like. So don't think by going overseas you're getting higher quality stuff. In general, the quality of care goes dramatically down. Sure, John. Happy to help. Kim, I actually had scheduled with you for an in-person evaluation through Carla a couple months ago for October 15th. I heard you say we're going until October 30th. Can you clarify? Yeah, I won't be here October 15th. So Kim, you may want to double check that. Make sure that that's right. Maybe it was a online evaluation rather than in-person evaluation, but I won't be here October 5th, or I won't be in Colorado October 15th. David, I see many do treatments in Colombia, Panama, Mexico, Beverly Hills. Is there a reason why I keep hearing it's better overseas? Yeah, again, it's not better overseas. I think as I just talked to you about the Mexican problem. Same thing in Panama, right? The biggest problem with third world treatments is that you get third world doctors, meaning that as a US medical provider, I can't get a license to practice in Mexico, Panama, or Colombia. The local yokels keep US doctors out for good reason, right? If an American doctor went down there, he would garner the largest share of the cash-paying rich patients. Because every one of those folks down there look to the United States as being the excellence in medical care. That's sort of the problem with those clinics is you take a huge step down when you go from US trained physician and this kind of stuff to the local yokel doctor. So again, be very, very, very careful. Again, I think of the Mexican doctor who was sticking a needle into the carotid. That would be instant malpractice in the United States. There's just no way to cut it that any differently than it was a completely inappropriate thing to do, but the patient didn't know. The guy that owned the clinic didn't know. So be very, very cautious and careful there. Daria, would repeating Regenxbio BMAC injections yearly be a good idea for pain arthritis and hip and other joints? Probably not. Edward, I couldn't find where they talk about ADI in the CATS paper. Could you show me? I don't have time there, but I just reviewed it with CATS, and their number was 3 millimeters was the max on ADI. That's off the top of my head, and I just actually reviewed it with CATS on Saturday. Ulysses, doctors need to be careful when it comes to treat the upper cervical spine. Absolutely. And I have cervical MRI 2 years old and a cervical x-ray video. I forget the name of this diagnostic test. Maybe DMX? Will that suffice for an evaluation with you for PRP? I have headaches, left side head and face pain. Usually that's good enough. If that's a digital motion x-ray, yes. Kimberly, I was in person scheduled with Carla. She's still a contact I need to reach out to. Yeah, Kimberly, why don't you send the email directly to me? This was my email address there, Centeno office at Centeno-Schultz.com. That one goes direct to my desk, and I will look into what's going on there, whether that was an error. If it was an error on our part, we will obviously try to get it figured out so that it works for you. Okay, guys, I think you guys are starting to run out of questions here. We've been going at it for almost an hour and 20 minutes. Any other questions I can answer that are out there, happy to do so. Again, today we're talking about the top 10 issues with spinal regenerative care and what we see out there so that you can try to look at those red flags yourself. Thanks. I just see a lot of MMA guys going to the bike accelerator place in Colombia on Instagram. That's the reason I asked. Yeah, I wouldn't send one of my patients down to Colombia. I wouldn't send one of my patients down to Panama. I wouldn't send one of my patients down to Mexico. That's just the bottom line, because the quality of what's being done is going to go way, way, way down. So yeah, I'm glad that the MMA guys, who obviously are not the brightest bulbs on the block, are happy to go down there and get needles stuck into their carotid arteries. But that's actually the Mexican clinic, not the Colombia clinic. But again, there's a huge local yokel doctor issue there, where the things we come to expect in American medicine aren't really the same, and especially in this area where you see that 99.9% of US physicians aren't trained appropriately to do this work. I'll give you a great example, and this is just a little learning that I had from this weekend. So this weekend I was out of the state lecturing at an interventional pain management conference, and one of the doctors that I had met there talked about injecting high-dose corticosteroids in a disc for a patient who might eventually get some sort of regenerative medicine procedure in that disc. Now, this is a highly experienced physician. This guy is a rocket scientist when it comes to doing clinical trials. This guy certainly knows a reasonable amount about regenerative medicine. He's been involved in regenerative medicine clinical trials, but didn't really think twice about putting in a medication into the disc that would destroy the disc's ability to heal itself. So that's someone in the US who is really at the top of his game, at the top of the pecking order when it comes to understanding how to do interventional spine procedures, but didn't get the memo that putting high-dose corticosteroid into a disc would probably destroy any chance for that patient to benefit from, let's say, later putting PRP into that disc. So that's someone here in the US who has 10 times the training of anyone in Mexico when it comes to interventional spine, or anyone in Colombia when it comes to interventional spine. So we go from that guy who should know that to the quality of care in those third world countries. And again, we get into Scaryville very, very quickly. Tanya, could CCI cause symptoms only on one side of your body? Yes, that's possible. And I'm sorry, I keep butchering this name. It's hard for me to say. Patata, maybe, I don't know. Is there anything that should be done before or after posterior PRP treatments to promote healing and good results? You know, you can do simple things, right? You can control your diet. If you've got metabolic syndrome, meaning you're overweight, high triglycerides, high blood pressure, you can try to clean up that. You can try to control systemic inflammation through supplements like curcumin with bioperine, taking high-dose fish oil, MSM, glucosamine. Those sorts of things I think you can control might be helpful. Ulysses, one of the views mentioned Dr. Otona Silva, their surgeon says he treats CCI. He says he treats CCI and cervical spine instability. Yeah, no ability to treat CCI there, but certainly when it comes to cervical spine instability in the lower neck, yes, absolutely. But CCI, no, there is no special training in that physician has had to treat CCI or to do high upper cervical injections. Again, you know, ever since and even before that complication, nowhere else but Colorado can do these procedures. Like any procedure, you've got to do a procedure or have to have done a procedure hundreds of times to be good at it. And you've got to do it dozens of times each month to be able to maintain that skill level. And there's just no place in the US or worldwide that has that kind of experience in injecting those sorts of areas. Okay, guys, so it is now officially an hour and 25 minutes in, and the old man's getting tired here. So I want to thank you for all your great questions today. There are no bad questions. We learn through questions. That's what this show is all about. We are trying to make sure that we educate patients, because educated patients get better quicker. And we're trying to make sure that patients get their questions answered, because this is such a complex space that it's important that patients have the opportunity to ask questions. All too often in today's medical care system, people get shoved into an office, get pushed out of the office 5 or 10 minutes later, 15 minutes later. They don't get their questions answered. They don't know which end is up. and they get very confused and frightened by the process because they don't get the opportunity to be heard. So this show is about allowing you an opportunity to get heard and get your questions answered. So I want you to have a great week. I will be here on Friday and answering a whole new set of questions. We'll have a whole new topic on Friday. Thank you so much and have a great week.